really laser photobiomodulation, light, we know, and we've known for a long time, that light can have a real effect on tissues in many ways, in tissue repair, in reduction of pain, reduction of inflammation, all these things. The problem was always getting enough power into the body to actually really make this effective. Class 3B lasers, I remember training myself on these a long time ago. Very effective, but you'd need to be on the tissues for a long time to get the effect that you really want. There was always the problem whether they could treat pain or could they treat the tissue damage. Were they getting any depth? No, they weren't getting any depth, and also they knew that a constant beam of light would actually work on tissue repair, and a pulsed wave would work on reduction of pain. What happened is class 4 lasers came into being, to getting more power in there. Class 3B laser is from 500 milliwatts, which half a watt, and a class 4 is anything over there. But once you start putting in, you know, 10, 20 watts into something, all you'll do is cook the person if you're not very careful. That was the next problem which came along. Take it back 8 years ago when I set up my practice. I used to work in the military. I wanted some sort of machine to help me with what I was doing with the patients. I'm a firm believer that the real power of healing people comes from this and these and your knowledge. But if you've got an adjunct which is phenomenally effective, always great to have as well. What adjuncts were there? I looked at Shockwave Therapy. It was a big thing, very popular everywhere, but the problem was it was just really not well tolerated by a lot of people, and it could only work on the collagenous structures. So I sort of, if I'm going to spend a lot of money, I said no way. I looked at class 4 lasers. But there was always the problem. There was the danger of cooking people. And the last thing I want to do is cook people, you know, by putting too much power into them. And then I came across this MLS laser. It was before Celtic had got the gig to do this. But through ASA, I got hold of one of these and I fell in love immediately. Why? This is not just a general thing about laser, because I'm hoping you have some basic idea of what's going on here. But it's really, what is the difference about the MLS? Yes, laser, but what is MLS? MLS stands for multi-wave locked system. What is going on? This is sending in 2 widths of light at exactly the same time, and it's class 4. One of those widths is sent in at 1.1 watts, which is, you know, a lot of power, but it's not enough to really cook you. The other wave is sent in at 25 watts, which is more than enough to cook you. That's going to cause all sorts of problems. The only thing is, this thing is 100% safe. It doesn't do any of those, because what it's doing is it's sending in the constant wave, and I always go in inverted commas with a constant wave, because it's actually not, it's frequency. We can make it constant, but it's frequency. The 808 nanometers, which works on tissue repair. How does it do that? It's sent in at 1.1 watts. It's continuous or frequent. It works by creating a protein synthesis, which starts the creation of ATP, adenosine triphosphate, which floods into the mitochondria of the cells, which starts regenerating the cells. They start repairing themselves, and we get a regeneration of the tissues. It does that, but the 808 nanometers as well, at the same time, it's also working on anti-inflammation. It stimulates the anti-inflammatory proteins to bind onto the ATP, and you get a huge reduction of inflammation. I'll come back on that in a second, because there's some fascinating stuff happening in America at the moment. No, I'm not talking about the election. Then at the same width of light, it actually, depending on what frequency we use on this, it can actually create more of a mechanical effect, which and create a little bit of extra heat in there, not really discernible, which will then actually flood through the, cause vasodilation, increase vascularity, and will wash away all edema. So we can actually have a massive change on edema at the same time. So you've got those three things coming from that one width of light, but at the same time, you've got 905 nanometers of light being sent in at 25 watts. That is a huge power. But why does this not cook you straight away? It doesn't cook you because it is super pulsed. What this 905 nanometers does effectively is inhibit all pain pathways. So it reduces pain massively. It is super pulsed. It is super pulsed to a nanosecond on, nanosecond off, nanosecond on, nanosecond off. What happens is the tissues heat, cool, heat, cool, heat, cool. What happens therefore is we get a raise in temperature up to about 42 degrees centigrade, which is probably justifiable. You might get a topical warmth, but you're not going to get any damage because the problems really start at 43 degrees centigrade and the true tissue damage starts at 45 degrees. So the diathermia which is caused is not enough to really cause any problems at all, whereas some of these other lasers, which will go straight in, one of them goes up to 980 nanometers. Why is that a problem? Because there is also this thing through research they found, the therapeutic window. The therapeutic window between about 790 nanometers and 950 nanometers is where this laser light suddenly goes deep up to 5-6 centimeters depth, okay? This is where we're having the effect right through all the tissues. Once you get to 950, it suddenly comes up to the surface again. And if you're, one of these lasers goes at 980 nanometers as well, not super pulsed like this. So all it's doing is causing scatter over the dermis, over the watery dermis tissues, and just heats you. And basically you've got to keep these things moving all the time. And if you stop to chat to somebody, you'll see smoke coming out of it. So we have just quite a phenomenal tool, which is doing four things. One is repairing tissue. I liken it to being part of Lance Armstrong's cycling team. You'll have heard me say this before, but instead of injecting yourself with EPO, you're regenerating the tissues by protein synthesis, by getting the ATP into the cells. You're just making yourself a better person physiologically by doing that. At the same time, you're getting the reduction of inflammation. At the same time, you're getting the reduction of edema. Those edema and inflammation are big causes of pain. The inflammatory mediators, massive chemicals going together causing pain. At the same time, you've also got, by reducing the inflammation, you're reducing pain, but at the same time, you're sending in 905 nanometers. This is the multi-wave lock system synchronized together. And that is sending in 905 nanometers, 25 watts, super pulse, which works on inhibiting pain pathways. So this is the massive point of this, is really reducing pain through four things: reduction of edema, reduction of inflammation, and inhibiting the pain pathways. And then you've got the bonus of actually regenerating the tissues at the same time. Now, I just want to, that is a rough overview of the laser, but just before I finish on that, let me consider the anti-inflammatory effect. And I think this is probably really quite remarkable at the moment, because some of you will know, some of you might not know, but there's an orthopedic surgeon in the United States, Scott Sigman, who uses the MLS laser all the time, and he has just remarkable results with it. He approached the FDA in the United States, the Federal Drug Agency Administration, and he proposed a trial with the MLS laser on patients with COVID-19. The problem being, where you have very acutely ill patients in ITU, they've got really one option to try and keep them alive. If they're getting really bad saturations and they are in bad way, the way they keep them alive is putting them on a ventilator. The problem with the ventilator is we've got very, very clear results from this. You are getting a death rate of 50%. 50% die, 50% live. So really, you put on a ventilator, it's 50-50. You know, every chance you might not be seeing a few days later. So the whole thing is to try and stop these people being put on ventilators. They started about a month, 6 weeks ago, the first trial with a patient, saturations, I think it was about 86 to 88% on 6 liters of oxygen. They did the laser on him with him lying prone, 14 minutes per lung, working in an average of 7.2 joules, which reduces when it goes through to the lungs, but that's what they calculated was going to be the right amount. Within 5 minutes of the very first application on this person, his saturations went up to 100%. Afterwards, they restored it at 98%. They did 4 days of, and they decided to do the trial in 4 days. 4 days, he was then taken out of ITU. He was put into a rehab area. Within a day, he was doing stairs, and then he was released. He was on air only, without any added oxygen. The FDA went, well, this is a bit amazing, and they've started doing a load more tests. Now, I think he's got 10 patients in undergoing this at the moment. Yesterday was the latest report, which is actually just exactly the same. I mean, it's just pretty phenomenal. 4 days, and the patient is being released on reduced oxygen out of ITU. I just want to show you what it's doing is, I don't know if you can see this, but one is the lungs before the start, very, very clouded, and just afterwards, like that. It's just quite remarkable. And this is just purely on the anti-inflammatory effect of this, this remarkable machine. You add on to this the effect of reducing edema, you add on to this the effect of regenerating tissues, and you add on to the effect of this inhibiting pain pathways. We've got an amazing thing in the orthopedic musculoskeletal world. What is very, very satisfying to my mind is that an orthopedic surgeon did come and say, look, we have such effects on inflammation here. Why don't we try it in this terrible pandemic we've got? Because I'm pretty certain it's going to work. The FDA at least said, yeah, let's give it a go. And they're finding something which is pretty remarkable, which is very common in a lot of situations like this. You know, we suddenly find, God, there is something amazing which has a huge effect. And it has done. And as I say, if it can help in COVID-19, brilliant. But just take what it's doing, the anti-inflammatory aspect, plus the reduction of pain by inhibition of the pain pathways, plus reduction of edema, plus tissue regeneration. And we got one pretty smart machine here. Right, that is my very brief overview. Hopefully it was brief enough.
That was an interesting 3 or 4 minutes, but thank you, Paul. That was really, really informative. And great that you talked through the things that are going on in America. And I can send you a link to what's coming from there, so to speak. So if you want that information, drop me on chat, and I'll make sure you're in the loop with the latest. There was a patient yesterday they've reported on, and again seen some really positive results. So you know, we're going to shout about that because we're really proud of this piece of kit. There's no doubt about that. So you touched on, actually one of the questions was, you know, Claire would like to know the uses of it, and I'll come back to that particular question, Claire. But I mean, Paul's covered quite a bit there, and you know, add in that you can treat wounds. I can give you an update on where we are with fungal nail for the guys out there, the podiatry guys out there. So we'll come back to that. Lots of questions coming in, so thank you. So I'm going to try and rattle through these, or we'll try and get through these now best we can. I'm going to try and keep them in categories if I can. So Paul, we've got I've got a couple of this question came in prior to from somebody who's trialing the laser currently, And the question is really between when do you use the chronic settings versus the acute settings? And to help you answer that question, or the question that the user is particularly asking me, I've got patient 1 scenario and patient 2 scenario. So if I can give you one scenario, a quick case history, because as a user, sometimes it's difficult to understand or difficult, not sure whether to use it, in the acute settings or the chronic settings. So here is scenario number 1, please. Women in her mid-60s, pain in left knee, has done for 5 years, had pain for 5 years, diagnosed osteoarthritis, medication, I might get this wrong, amlodipine and
Amlodipine, yeah.
Thank you. Okay, recent flare-up, VAS score of 8 out of 10, with edema, left knee very tender. How would you treat with the laser? Would you go anti-edema setting first, followed by chronic arthritis pain setting? So,
with whether you're using chronic or acute, it comes down to the pathology. This is just very, very clear. We've got to know what we're treating. Now, what I can tell you now, not specifically this lady, there is one condition where I actually go in straight away with chronic and I give it the full whack. And I probably shouldn't do this, but I find it works. It works very well. Hopefully you all know we can have the chronic and the acute setting, which we do, actually only affects the scan. I'll show you on the machine afterwards. But when we actually go and treat the pathology, so again, when we're using this machine, what we really like to do is a global approach where we do the area scan of all the tissues surrounding this pathology, and then we go on and treat the pathology itself. When you get onto the settings of here, the only time you can change from acute to chronic is on a scan. You'll see the hertz will increase, the intensity will increase. We're putting more power in. It all comes down to what we're putting in. We always want to put in more power with the more chronic problem. That is the joules per square centimeter. How many joules per square centimeter are we putting in? As I said, when they're treating the inflammation on the COVID-19, they're going at 7.2 joules starting off, but because we're going deep through everything, they know it's much less getting in and lower down. And that's why, because it's a very acute pathology. We don't want to blast that with too much power. We could get this set so we could be sticking in 30 joules per square centimeter. It's not going to have the effect, because where you're going to have the effect on an acute situation is keeping the power down. On a chronic situation, power up. Right, now, that comes down to actually using your brain a little bit on this with the patient. If I go straight onto a setting on here, in fact, why don't we just have a quick look at this, shall we? If I just go onto here, I'm just going to use it on the handset. If I go onto the machine here,
just to everybody at this point, if you want to press speaker view, you'll get that in large screen. Just a quick tip, as Paul's gone to there. So I'm just going to go speaker view myself.
Right, if we get onto here, this is what we see straight away. What we're going to do is we're going to the knee, and we're going to say what we're going to do is the global approach. So we don't go onto a pathology or anything. We're going to go onto the scan phase. We're going to scan all around there. It comes up automatically acute, 300 hertz, 4 minutes, 25%. But I can tell you now, Mrs. whatever her name is, who is 60 years old, had a knee pain for 5 years, and she's on the amlodipine, which I don't, it's something to help with the, because it's a steroid, it's going to decrease some of the inflammation. But again, if we could steer clear of these steroids as much as possible, it is better, because steroids, what they do is they actually halt, they will reduce inflammation, but they will halt the healing process. This is another subject completely. So let's leave that to one side. I would probably say to her, let's just see how it goes, see if we can stop using your medication there. But what we do is we're going to press chronic. So you can see straight away it goes up to 500 hertz, 75%. Now, this is what machine gives us, and the machine is very, very good. But in this situation, 5 years, osteoarthritis. This isn't osteoarthritis. I've said this before on these webinars. It is not an arthritis, it's an arthrosis. She has really quite chronic degeneration in her knee. I know this, I haven't even seen it. I know exactly what's going on here. And I would not even mind just going up to here to 100%. Look what happens. It's come up here and it's saying the total joules is 103. But if I go up to 100%, it's now going up to 136 joules. So I'm putting quite a lot more joules in there. Why am I not worried about a rebound effect? Because this is an arthrosis. This has been on a long time. If I was being ultra safe, I would probably treat the scan as it says here. But I tell you now, I'd feel quite safe about going 100% on there. And I'll scan it. And when we're scanning it, we're moving all around all the tissues around there, okay? When we finish the scan, it's only 4 minutes. We finish here, when we come off here, and we're going to go on the knee pain, okay? Right, it comes up 700 hertz, 8 minutes, 100%, 6 points. Right, now, we're already getting 100% here, knee pain. It's very intuitive, this machine. I think it probably knows that this is generally going to be some more of a chronic situation. What we've got here, we've got 14.65 joules per square centimetre. I think, if I wasn't totally sure about this lady, that's what I would give her straight away, okay? But if I wanted to go a bit more power, I would easily just have to press the CPW, which makes the 808 nanometers, which is frequency. You can see it's frequency 700 hertz here. It actually just makes it continuous. And with it being continuous, then also the 905 nanometers, which is synchronized with it, is on a much longer as well. And look what happens to the joules. So we're at 14.65, and I press that, and it goes to 29.86, okay? But even I am not a complete maniac to do that. I'm going to leave that in my pocket later. What I would probably do here is, sorry, when I press that, you can probably see the frequency goes, and it just goes continuous in there. What I would probably do in this situation, I would say, let's get some more joules in there. Let's come down to 75% and go there. That's going to give me 22. I still might feel that's a little bit much. If I come off here, I go 50 and go there. It's giving me a tiny bit more, 15.85 joules per square centimetre. And do you know what? As a safe thing, and I've always got stuff to move up, I would probably give her that first. And then we have to have the protocol. How are you feeling? What's happening? The next day, 2 days later, let's get you back in the room. And she says, I haven't really felt any change. Right, let's give it a bit more, okay? And that's where we can probably go 75% and CPW. Now, also got, we can come up to the 25 or 29 joules, was it? I can't remember, where we can give it a lot more. And I can do this in this situation because I know this is a very chronic arthrosis. Now, if you've got something and you're not sure, always go safe to give you what the machine does, because the machine is much better when you go into the pathology. It's much better at giving you more of an acute setting, acute, really subacute setting. I think that's what we'd say. It's a subacute setting, and stick with those. And then you've always got ways of pushing up the joules per square centimeter, depending on what the person said. If she'd said to me, I'd put in 15.85 joules or whatever, she said, yeah, do you know what, I feel quite good. Well, I probably wouldn't feel much reason to go much higher than that. I'd probably leave there, give her 2 or 3 sessions. How's it going? Oh, it's really good. can't believe it. This is I've been seeing people for years and nothing's happened, and this is actually really good. Yeah, right, that's what I expect. We could probably try a little bit more power just by messing around with those settings and get it to really somewhere where we're actually sorting her out for the first time ever. In a situation you're not sure, always go more acute. There was one person who I'd done a training with, and he'd somebody with a neuropathy. He treated it as the machine said, and this person was saying, "Wow, fantastic!" And then he thought, "Wow, this is fantastic. Let's give it more." And he put the CPW without even adjusting any of the other things in, and he gave it to them again. They said, "Oh God, no! I've got pain everywhere after a day or so." Why? Because they were getting a rebound effect. They were getting too much power in there. In this, a neuropathy is generally more of an acute situation. So it's knowing the pathology and reacting to what the pathology is. Don't go gung-ho crazy thinking more power is better. It's not always better. So go with what the pathology is and decide, is this acute, is this subacute, is this chronic, is this very chronic? And that's the way I think you need to look at it. Because if you go about it just more power is better, you are going to send a lot of people into things like, God, this machine doesn't work, this is no good. And it's not that the machine doesn't work, it's because you don't work, because you're just being a bit silly about this. Does that make sense?
It does indeed. Thank you very much. We have got a patient number 2 as well, but I think we'll come back to that because that's brought up 1 or 2 questions as we've gone along. So I'll try and keep this as interactive as possible.
Okay.
Only fair to the guys that are here. So where did I get to? Quite earlier on, Alison asked, she was listening intently, I know, but she missed, how deep did you say this type of MLS laser penetrates?
Probably depending on which level you are between 790 and 940, and we're going 808, 905. We estimate, or sorry, I shouldn't say we, the scientists and the makers working out of the faculty, medical faculty at the University of Florence, are saying 4 to 5 centimeters definitely, but quite often they've been measuring up to 6 centimeters. So your quick answer is there between 4 and 6 centimeters.
Okay, thank you. Great. Here we go. Look, I did say I would ask all questions. What are the downsides of using MLS laser? That's hardly going to be...
Well, the downsides. Used correctly, there are no downsides. Look, if you slap way too much power into a very acute injury, there is a downside from a rebound effect, but it's not a permanent downside. It will be a very temporary downside, 48 hours or so, where the person might be in more pain, but then you'll speak to them and you'll say, be honest is the best thing. Say, look, I'm the idiot. I put in far too much power. I realize I promise you, I can pretty much guarantee you after 48 hours, this should be back to where it was, if not slightly better. But I've been the mug. I've been the idiot here, and I should have known better. I put far too much power in. If you just go with the settings that they give you for these things, you're not going to put too much power in. It'd be so unlikely, but you can always build up. And that's why I always recommend to people build up from what you've got there, depending on the pathology. So there is the rebound effect, but very short-lived. What is the downside? There is no downside. It is remarkable. It works on tissue regeneration. It works on reduction of inflammation, therefore pain, reduction of edema, therefore pain, and it has the 905 nanometers sending in the pain pathway inhibition. There is no downside. That is used correctly. The downside is, if you want a downside, is really all connected with the contraindications, which is if you have a patient with an active cancer, what we're doing is we are stimulating in quite a powerful way at a cellular level. Cancer is rapidly dividing tissue, cell division going crazy. If you have a patient with an active cancer, do not use, because you'll likely speed this cancer up. Where do I stand on cancer treatment? If the person's got, I know, a thyroid cancer, I've got to treat plantar fasciitis, would I use it? No, I don't, because I've no idea until they get the all clear, the remission from the consultant, what stage cancer they are. Is this, or they might say it's 3, but it can very rapidly go to stage 4, where it's metastasized everywhere. And I'm treating the foot, and I'm probably speeding up some bone cancer down in the lower limb. No, I don't do it. If they've got cancer, an active cancer, I do not touch them with this machine. If they are in remission, however, they've seen the consultant, and they've just been given the clear by the consultant that you're cancer free at the moment. We call it remission because cancer can always come back. But they're in remission, then use it. And you're absolutely 100% within your rights. If the consultant has given the all clear, then yes, use it. Use it anywhere. Do not use it directly over the thyroid gland, right up in here. Do not use directly over a pacemaker. If a person is pregnant, again, we're talking about cellular activity, dividing tissue. If a woman is pregnant, I again do not use it on the foot pain. I'm being ultra safe, but the simple reason is this, and I've said it, which is probably the most politically incorrect thing you can say. But
I'm gonna mute you again. I'm joking.
Okay, but if the lady is pregnant and we do something on her foot, and little Johnny has some deformity, I usually say 2 heads or something. But anyway, they can always put you on the bottom of a long list of people on a suit, because the lawyer will say, oh, you had lasers, or what? Hang on, and they'll check it out. Oh, this might affect it. So they're always looking for someone to get the money off. And because physiotherapy or podiatrists will have some insurance, they'll be put, you'll get off this very, very quickly. But it's professional. You don't go there. You don't want to get in that scenario whatsoever. So I don't use it on pregnant people. There's one other area where you've got to be quite careful. And I've said this to lots of people. There's lots of papers written that this could possibly happen, but I haven't found one example of where it has happened, is using the laser directly over the growth plates of a child, of the long bones, because there is evidence that this can, at a cellular level, it will stimulate the cells thinking, okay, it's time, little Johnny is 18, but he's not, he's 9. The growth plate seals up, and then he ends up with 1 long leg and 1 short leg. Have not come across a single case where it has happened, but that is the science behind it. So just don't do it. But use it around the areas, if someone's got the Osgood schnitzels, you're not going to be directly on the growth plate. Sever's disease, right on the calcaneus, you're fine. That should be fine, but just don't go directly on the growth plates, and do not work it on, pregnant people. Do not use it on somebody with a cancer, because these are downsides, because scientifically we know it's going to increase cellular activity. We don't want to do that. While we're on contraindications, there's a few little precautions. If you have a very elderly patient on masses of blood thinners, just be slightly cautious what you're using settings, because we will be, if we have the Hertz out quite high or anything, we will be actually increasing vascularity, vasodilation, and if there is any leakage in the tissues, we don't want to create a bleed through there. But that is just a very slight precaution, nothing to really panic about.
No, that's great. That was the second, thanks for covering the contraindications. That was the second part to Olga's question about the downsides. And we can send out a list, if you like, that come with the
Listen, sorry, Steve, I've forgotten. Probably the biggest downside is not following what you need to do with this, which is dress up like a rock star, dress up like Bono. If you're using this laser, get these on. Make sure your patient has these on. Anybody else in the room has these on. You have a sign outside the door saying laser inactivity, which you will get with the system, because this laser is class 4 laser, infrared light. You cannot see infrared light, but it will bounce off anything, and it will probably go, if it goes into the retina, it can cause damage to the retina, even blindness. So that is one thing to be careful about. Make sure you're wearing these things. Sorry, I should have said that probably first of all. Let me just show you something very quickly. This is from a patient I was just doing earlier today, using the Charlie head. As I said, you cannot see infrared light. When you put this laser on, you'll see red everywhere. Well, on the wand head, it's a small area of light, of red light, and on the Charlie head, big area of red light. That is just some LEDs which are going around, which are showing you where the areas we are covering. Here I've got the Charlie head on the patient's knee. This was done this morning. Right, you can probably see, your naked eye can't see this, but a camera can. I'm not sure if an iPhone can, I think can, yeah. But you can see it's all white around there, and that is where the infrared light is going. You can probably even make out just a little triangle in here as well, which is the 3, can you make anything out there? I'll show you a better one.
Not quite.
Sorry, I should put these. I'll find a better one. Just give me a real. You might see this on the fellow's shoulder. Can you see a little triangle in there?
Just about picking up, but I know what I'm looking for. So yeah.
Okay.
Yeah.
There's a triangle in there, which is the point of the 3 heads in that Charlie head where the focus is. And so you've got the 3 areas around there. What I'll do is, next time we do some of this, I'll get some of these photos downloaded on the computer and I can just share them. But yeah, so remember your glasses, very, very important.
Absolutely, you've got to style it out with the glasses, absolutely. Yeah. Okay, now where did we get to on the questions? I think on the contraindications we kind of covered that. Although there was a question about the amlodipine is for high blood pressure. Is that a contraindication? High blood pressure is not a contraindication, is it? I don't think.
Well, again, if we've got high blood pressure, again, we can be creating extra vascularity. So there's technically we could be creating more blood flow. So just be relatively careful, but it's not a contraindication.
Would that be a scenario then where you've got the presets on there, which, as you say, are pretty reliable, and we tend to suggest people go by those. But would that be? But at any point you can override them, as you quickly demonstrated.
You can override anything. Yeah. And
a good example where you might say, okay, I'm just going to reduce the intensity because I know of this patient's taken that particular medicine. Would that be an example of where you might override the?
No, this is all very safely set up, and I would probably leave it where it is. Where we can actually really make changes is really up. So just don't go and stick everything you've got into there, because then you might have the rebound effect. Okay, I've said, go up in stages. I've often had a patient where I've literally, it's the really big chronic arthrosis where I've actually said, right, sod this, bang, everything, 100% CPW in the knee, and it's had a good effect. But just be very careful about that.
Okay, so on that point, actually, that's relevant to a question that's come in. I've jumped a couple of questions, so I won't miss any, I promise everybody. So here we go. So you're getting a good reduction of pain. Would you then increase the power or leave it as it is for the duration of the course of treatment?
I would, if we're getting a very good reduction of pain and things are going well, I'd probably leave it where we are. You've always got more if you need to. If you suddenly find that the effects are wearing off and they're not going to, you know, a bit of pain's coming back, give it a bit more, okay? But work it till where you're finding you're getting the good effects. And you'll find that very quickly, because if you can, and I know this is a very difficult thing to do, but if you can get the patient in the situation, you know, coming in, and if you can give it the 3-2-1, you're going to find out very quickly in a day or so, how was that? Nothing. Okay. Oh yeah. Wow. Good. Okay. And that tells you, do we need to adjust this in any way?
Well, thank you. Okay. Well, this next question shows that people are paying attention to you. I note it states knee dislocation. True dislocation is under medical emergencies. Therefore, why would you treat with the laser?
I think what they're talking about, the knee dislocation, is patella subluxation. It was probably written by Italians. So knee dislocation, it is referring to patella subluxation. The thing has come around, it's been reduced, then start working on that. There's so many other things you need to work on as well. That's why I've said this to every patient, every person I've had to do a demonstration with. I say this is something which Celtic probably don't want me to say, because very simply, no machine is the total answer. It cannot be the total answer. What it is an adjunct, but such an effective adjunct, because we're getting reduction of pain. If you have a patella subluxation, what the person is probably likely to do is probably want to keep it in a brace, not move the bloody thing, and they're just going to get atrophy. They're going to get all sorts of problems. They'll end up with patellofemoral joint pain because this thing will be maltracking everything. We've got to get, alongside getting this pain reduced and getting the tissue repairing, we have to get the VMO firing. We've got little ways of doing that with, you know, just some quarter squats with adduction, massive adduction. You'll get an overspill into the VMO, really get that firing up. We've got to get this knee moving, because it's not just the subluxation area. The whole joint needs a bit of WD-40 on it. How's it going to get that? By stimulating the capsule. How do you stimulate the capsule? You move the knee. If you've got it stuck in one position, you're not bending or anything, then you've got a problem. You are going to have a much bigger problem later. We want to get this thing moving. If we reduce pain, we can get them actually doing what we need them to do. And when I've spoken to people about this, I will say it again. It's not just the machine, but the machine is such a massive helper in actually getting the tissues to adapt. Yes, this will start regenerating the tissues, but the main way to actually change tissues, and we know we can change tissues, whether it's a very young person or a very old person, we can still change them, but we can only change them. Tissues will adapt to the stresses you put them under. If you don't put them under any stress, they will not change. They will just degenerate, okay? So we need to get these things moving. We need to get the correct muscles working. And what we're doing is we're actually making it effective that we can do this stuff, because we're reducing the pain to such a level that they're feeling, wow, this is great, this is fantastic. And then the cumulative changes are just fantastic.
Brilliant, thank you. Olga's come back and said thanks for that. That's great. There's a couple I want to go back to, which I'm gonna that I've missed from earlier on. A couple of quick ones I'm going to quickly rattle off though. Claire, you referred to 3-2-1. Claire asked 3-2-1 question mark. So basically, Claire, very quickly, we typically suggest when you see the patient, we do a 3-2-1. So 3 times this week, twice next week, and once the following week, and then review from there. It's a great opportunity for Paul to do his thing with his fingers as well. Can you do the 3-2-1 there, Paul?
Yeah. Let me my dusty bin. 3-2-1. Okay, you back on.
3-2-1. 3 times this week, Claire. 2 next week. That's a protocol we typically suggest. It's not every patient might have different scenarios, but that's typically what we do. And it's a good way of signposting to your patients how often you might need to see them.
What I was just going to say with the 3-2-1, that sometimes puts people off thinking, well, my patient doesn't want to come in and spend a whole load of money 3 times a week. And you don't have to do that, because literally, if you decided, yes, look, we need the laser. We've seen them at one time, 45-minute session, 30-minute session. But you know what? We've got given you all this stuff. I need you to do this stuff. This is very, very important. And they say, well, I can't because it's too much pain. Hang on, let's give you the laser on the very first session. You'll find that this is helping things. I need you to start doing this. And as you're feeling it's getting easier, do more of it, okay? But 3-2-1, I only need them in for 15, 20 minutes max, because the treatment times are so relatively short, including a scan and the pathology. I can see them in half the time I would normally see them. So I would charge them half as much. What I do is I'm a terrible businessman, but I sell 6, which works out only 3-2-1. I sell 6 laser sessions for, I can't really have to speak to Teresa. I think it's £120, okay? So it works out £20 a session. I should make that more, it should be 25. But anyway, it doesn't really matter, because my normal sessions are 55 sessions for 45 minutes and 45 minutes for half an hour, okay? £45 for half an hour. If I'm doing a 50-minute session and I'm getting 2 lots of 20, I'm going to have to change the prices slightly, but not too much, because then I can actually make it exactly the same, but just burn 2 of these people, in there, laser, get out of my office, next one in, okay, bang, 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 and do it like that. And then we can have the effect on these people. The biggest problem you're going to have is people saying, can they get to your place 3 times a week? That's not my problem, because it's not my need. But I can virtually guarantee you, if you do this, we're going to have a big change.
Yeah, and this comes up, it's an interesting one, because this comes up, the practitioner equally will turn around and say, I can't fit somebody in 2 days' time, 3 days' time. So it's
Well, that is a problem I'm having actually at the moment.
At the moment, it's an interesting one, so...
yeah. Well, I have my other physio, and I can even, if I have to, and I haven't done it so much, but if I need her to see people, just do the laser. It's in my notes exactly what we're using, exactly there. She can actually apply the laser.
Yeah. And worth keeping in mind that typically the treatment time today, when you've seen them for the first time and you choose to use the laser, you don't know before they're coming in that that's what you're going to do necessarily.
Well, no, I don't. But if I've got 45 minutes, I can easily treat them, to find out everything, do everything I need, subjective, objective. I do my mobilizations, everything I need. Let's give it a bit of laser. And you know what? This is going to require 6 sessions of laser.
But the second treatment isn't going to be 45 minutes. That would be...
No, it's going to be 15 minutes.
So can you find 15, 20 minutes in 2 days' time for that patient? So we appreciate it. It's difficult, and the times at the moment are not making life any easier. But that's the consideration, I suppose, for the patients. I do have one practitioner that actually allows time each week, a couple of hours slots each week, a couple of days a week, where they say, look, I need you back, and they allow that time in their diary. Every practitioner is different. You have different ways of keeping your diary. It's something that comes up a lot. And actually, on the 12th, quick plug here for our next webinar, on Monday, the 12th of October, we've got a user, Kirsten, who's a podiatrist, joining us, and it's called Value to Your Practice Using Laser. So we will cover this in a bit more detail then, when we've got Paul here. It's great to keep it from the clinical side of things. So yeah, we'll be covering that on the 12th of October. So do join us, and we can take questions around that then. But actually, there might be one more question coming in about that. Is 15 minutes the average time of treatment? Well, typically it's between 3 and 10 minutes per treatment. But what you'll see Paul do is he might do the scan first and then the trigger point. So you've got 2 lots of, say, 7 minutes on average. So typically 15 minutes using the laser, Paul?
If you're doing a big back problem, you'll be probably 20 minutes. That's where, you know, that's a longer period. But you know, you've got to have some cleaning time in between. So in this current time, I've actually got I'm lucky because I've got 3 treatment rooms I can use, and 2 physios, and we can practice manager can go in and tidy up. I get change myself, and then go into the next room with the next patient, and we can keep things going pretty much non-stop. But in the current time, I know for a lot of you, you're going to need a good 15 minutes in between. 15 minutes clean up, next one 15 minutes. So it's actually cutting down probably the amount you can do, but not by massive amounts. It turns what would technically be a 30-minute session into a 45-minute session, if you see what I mean.
Sure. Yeah. Let me just, I've got a question on that, and I'm conscious of the time, everybody. Lunch hour is probably coming to an end for some of you. I know 1 or 2 have said thank you and have had to dash already. But I'm going to ask this question, then I'm going to double check everybody that I've not missed any of your earlier questions. But actually this comes up a bit with regards to the M-Phi. So those of you that haven't got the unit or don't know what the M-Phi means, that's the basic unit with the handpiece. And then we have the M-Phi 5, which basically is the ultra head. So the bit that Paul showed a picture of there, where we've got the free diode. So the M-Phi and the M-Phi 5, just to give people a bit of background, other than time saving, this is what prompted the question, other than time saving of using the M-Phi over the M-Phi 5 over the M-Phi, are there any clinical benefits as well?
Not, that's true. That's with the Charlie head there as well.
Thank you, Paul. That's great.
If you look at that, benefits. Benefits in time, yes. What this is actually doing, hang on, let me just get back into the room here. Right, what it's doing is, the Charlie head is doing exactly the same as the wand, but it's got 3 heads in there, and it's 20 centimeters away, so that's where they're all synchronized to come in to cover a big area. So what you can do is you can cover bigger areas massively quickly using that Charlie head. What are the other big advantages are, the most simple thing is you can actually treat 2 completely separate pathologies at exactly the same time, so you're not wasting any time there. The fellow's got his plantar fasciitis, treat it with the with either the Charlie head or the wand, and he's also got a shoulder. He's got a rotator cuff problem. Treat the shoulder at exactly the same time. So what you do is, it's just very simple. When you've got the both things, let's get off here. When you've got both things, when you've got this system, the ordinary one, the MPHI 5, is it? No, the MPHI. Yeah. You won't see this little box in there. That's the only thing you can't see. The only reason that box appears is because we got another cable into the green area on the back of here, which is for the Charlie head. What happens is, once you plug that in, then this comes up. So what I can do is, I'm going to set my, I'm going to deal with my plantar fasciitis. Actually, I won't do plantar fasciitis, but I'm going to do with his knee, which we were doing before. I'm going to, oh, that's on 2, hang on. 1, I'm going to the knee, okay, and I'm going to do my scan first, chronic scan, 4 minutes, okay, I do that, and then I'm going to come in here, and I'm going to do my I'm going to do my knee pain. That's 8 minutes. That's 12 minutes. 12 minutes to do his knee. That's one thing. At the same time, what I'll do is I just press on here on the little box, and that gives me my Charlie head. And what I'm going to do is rotator cuff. So I'm just going to get a rotator cuff. This, you can actually get away without too much scanning because this is actually covering big areas. But let's say I go straight into his rotator cuff, 10 minutes. I'm not going to mess around here. Is it how chronic it is running? That's what it is. It's not going to change the time. It's still there. That's what it is. So we set that going. We've got that going, and we've got the other one going. Boom. And I've got two things being treated at exactly the same time. Okay, different pathologies, different settings, everything. Where can you save time by using both at once? You can use either the one to scan his surrounding tissues for his plantar fasciitis at the same time while you've got the Charlie head going right on that calcaneal tubercle while we're treating the plantar fasciitis. So we're changing a whole treatment into 5 or 6 minutes.
Yeah, now and just to stress there to everybody, the M-Phi, the one with the handpiece that it comes with, the M-Phi 5, they're both exactly the same under the bonnet, if you will. So there's no catch. We do find that a number of practitioners are upgrading to add the ultra head later on, and the unit they originally have does that. As Paul said, it's got 2 channels, so it's not a case of having to upgrade and you wish you brought that first time round. So what we find, a lot of practitioners do go the M-Phi first, but not invariably.
Steve, it makes your life so much easier that you literally can you can literally treat 2 completely separate pathologies incredibly effectively at exactly the same time, and you're saving huge amounts of time.
There's definitely the benefit of having an M-Phi 5, i.e. the ultra head on top of. For a lot of people, a lot of practitioners, it's a big investment to make. So sometimes they start with the M-Phi first, but as I say, there's no catch. That's okay. You can always then upgrade later on. There's no catch. Oh, well, you should have bought that unit. You can't add this. You can't add the ultra head to it. So we're a fair company. So, that is not an unusual scenario where people add the ultra head to turn it into an M-Phi 5 later on. And as I say, there's no reason why you can't do that. And there are the benefits. There clearly are the benefits of time. So it was interesting to see if there was any clinical benefit on top of that. I think it's really the answer is it's a time saver. You can go beyond that. You can even get the robotic version, which is even more expensive. Again, our cousins in America love it. They sell it that they can leave their patient to it. I'm not sure if we're too keen on that over here. So, quite right. So Paul's nodding his head. We don't really see the real benefits of the robot.
Well, I want to do some supplementation.
I'm not going to put it down too much. There's a couple of users out there, and
yeah. No, look, they use the robotic one when they're doing the COVID-19 because then they can just leave it.
Indeed,
all the areas.
Yeah.